Hello, my name is Aaron Mates. I'm a foot and ankle surgeon with a background in sports medicine, and we're going to talk about some foot and ankle injuries. Originally, when I trained, we did primarily foot and ankle injuries, but we also developed protocols as well as different treatment regimens for injury prevention for the shoulder and the knee. So tonight we're going to focus on some ankle tendon injuries that are common that you'll encounter in a sports scenario, whether it's high school or collegiate athletes. Um, so beginning with the topics, there's different things you can talk about. Everything from the anterior aspect of the ankle to the posterior aspect. Everything from Achilles rupture, insertional Achilles tendonitis, non-insertional tendonitis, peroneal tendonitis, subluxation dislocation, and peroneal tears. So we'll talk about some background, some anatomy, some pathophysiology, clinical presentation, different imaging, different treatment modalities, as well as complications that can arise. Most important thing to keep in mind throughout all of this is the key to sports medicine is injury prevention, as well as athletic performance and preventing these injuries, not just treating them after they've occurred. So first we'll talk about the Achilles tendon. Very common injury. Gastric soleus complex is a complex structure. The Achilles tendon is the largest, strongest tendon in the body. Actually, the fibers insert on the medial aspect of the calcaneus. So a lot of times when you have Achilles pathology or tendinosis, the foot assumes an equinus position or is plantar flexed. The patient or the athlete's not going to want to dorsiflex. Therefore, leading to a contracture. This exacerbates the problem, and there's a vicious cycle or loop of pain that is involved. Ruptures are the most common in people in the later decades in life, usually around their 30s and 40s. You're looking at a male predominance. You're looking at the weekend warrior. A lot of males in their 30s and 40s who were athletic when they were younger, developing these injuries, typically playing basketball. It's a sudden plantar flexion against a everted or dorsiflexed ankle. There's about 18 per 100,000 every year, usually middle-aged males, as I mentioned. History of quinolones, corticosteroid injections. They should never be injected anywhere near the Achilles tendon, as well as anabolic steroid use, so that's something you'll have to look out for. There's also a risk of 26% return to play. So these are significant injuries in an athlete. With a professional or collegiate athlete, when they have an Achilles rupture, more than often they're going to have surgery, and there's a very low return to play afterwards. So some anatomy. Gastric soleus complex is a unit that combines down to the Achilles tendon inserting medial, as I mentioned. To test these two structures, you have the knee in extension is going to mainly put strain on the gastroc complex, whereas in flexion, you'll take the gastroc out. So that's how you can test for a contracture and isolate between the soleus as well as the gastric muscles. Some medial anatomy, as I mentioned, there's a twist, so they insert medial. This is significant because when there's a pain, you develop a contracture, and the contracture causes inversion of the ankle. Inversion leads to lateral column overload, which can cause fractures on the lateral aspect of the foot, such as a Jones fracture. The anatomy for the vascularity of the tendon is a watershed area, 6 centimeters from the insertion of the Achilles into the calcaneus. This area is usually where the ruptures occur. So this is demonstrating the watershed area, as well as a sural nerve. So you can have a sural neuropathy, which can occur with these inflammatory disorders, as well as with repair, which needs to be monitored for CRPS or reflex sympathetic dystrophy. It's just an axial view on MRI showing what you're looking at. So most of these tears in an athlete especially are going to be getting an MRI to evaluate the tear as well as the tendon surrounding the tear to be sure that there's no chronic tendinosis, which will complicate repair. On X-ray analysis, you'll have this little black triangle in the back here, and that's representing Keeger's fat pad, which is a triangle of tissue. When this is obliterated, you know you have a tear just on X-ray analysis alone. This is important area of inflammation as well as blood supply for the Achilles tendon. So pathophysiology, there's different studies that look at this, but as I said, it's a sharp, unexpected dorsiflexion to the ankle with contraction of the triceps surae. So the ankle's dorsiflexed, and there's a eccentric and concentric concomitant contraction with plantar flexion. So usually like stepping into a hole or pushing off playing basketball with a knee and extension, rapid push-off. So this can happen with going up for a ball. You can have outfielders have this injury, basketball players, football, especially like offensive linemen with a knee extended. There's a predisposing factors that you can think about for these injuries, such as medical disorders, lupus, endocrine disorders, gout, rheumatoid arthritis. A lot of these patients are going to have chronic tendinosis before they have a rupture. So we talked about the different issues, including the mechanism of injury, the watershed area with the decreased blood flow, leading to chronic tendinosis, and the inability to repair tendon damage. The difference between tendonitis and tendinosis is the tendonitis is acute inflammation with good blood supply, leading to an inflammatory response. The tendinosis is a chronic degeneration. So with tendinosis, the tendon is turning, it's called mucoid degeneration, where the tendon itself is becoming friable. That's what leads to the rupture. So examination is very simple. There's a painful, palpable gap in the calf. Thompson test is performed. That's where you squeeze the triceps surae, and there's a obligatory plantar flexion of the ankle. At that point, you know you've got a tear. You don't have to have these things. The best thing that I like to do is lay the patient prone, bend both of their knees, and then just look at the resting posture. The one with the tear, the ankle will be more dorsiflexed compared to the contralateral limb. So this, like anything in orthopedics or sports medicine, is you want to always compare it to the contralateral limb. Whether it's a knee injury, shoulder injury, elbow, wrist, foot and ankle, I always look at the contralateral limb first to assess for any pathology. So there's a palpable gap that you can feel. And there's a Thompson test where you squeeze the calf. You can see the one closer to you, which is the patient's right leg. The foot is not plantar flexing. So imaging, MRI, different studies are useful and helpful. They're not always necessary, but for surgical planning they can be. But here's an example of a complete tear on the MRI T2 image. There's Kager's triangle I was talking about earlier, which is the area behind the tibia, which is obliterated in a tear. You've lost the fat pad due to the inflammation and swelling. Ultrasound is also utilized if you have this in the training room. There's some great new ultrasound modalities that can be used to assess it. It's also good for detecting chronic tendinosis or inflammation in somebody who's having some insertional Achilles tendonitis. MRI again showing some tendinosis at the tear site. So differential, this is a big one. Very common injuries in athletes is hamstring injuries, medial gastroc injuries, plantaris tendon ruptures, Baker cysts, DVTs, leg or calf contusions. So whenever you have an athlete who sustained an impact injury, you're thinking contusion, gastroc tears, partial tears, grade 1 or grade 2 are extremely common, especially in the medial head. It's the larger, stronger head in the gastric soleus complex. Plantaris tendon ruptures are extremely rare, not as common as the gastroc. The other one to think about is a soleus tear or soleus strain. That's actually more common than I think a lot of people give credence to, so that's something that needs to be ruled out with the silver skull exam, where you bend the knee and test dorsiflexion and extension and flexion of the knee. So who's going to get surgery? It's usually going to be people who are younger or athletic. That's pretty much my protocol. There's a high risk of injury, and the studies are very different about post-operative return to play. It's usually going to be a year. This is a huge, huge injury. It could take up to a year to get full strength back. So, most professional athletes, this is a career ender. You're finished after this. So, the non-operative treatment is a great option. There is a slightly higher incidence of re-rupture, but there's no incidence, obviously, of any wound breakdown, which is what you worry about with operative treatment. Operative treatment does have a slightly lower increase or risk of re-rupture. So what I do is an accelerated protocol of weight-bearing status using Cam Walker boots. So if they're going to initiate non-operative treatment, I get them going pretty quick. Put them into a cast and then back into a boot for about 2 to 3 weeks, and then gently bring the heel down, bring the foot up using heel lifts. Operative treatment: young, active, athletic people, no medical issues, and it's got to be an acute rupture, which in my hands I like that to be within 3 to 4 weeks. So surgical intervention, just basically checking the landmarks. Most incisions are going to cheat medial because you worry about the sural nerve. For mine, we go straight down the center, so this isn't the incision that I use. This is one I got offline, but here's the dissection down showing it's actually the plantaris right there, but you can see the tendon itself is just obliterated. It's destroyed. So there's a deeper dissection. You can still see the plantaris tendon, which is intact. And it's a vestigial element. It has no function at this point, so it's anomalous. After primary repair is completed, there's different techniques you can do. Most docking techniques are pretty strong. I like to use the gift box technique. It gives what's called a rip stop to prevent the sutures from propagating once you've repaired it. Typically, this is how it looks when it's done. When it's completed, the patients are in a plantar flex position, I call it the dancer position, so they lose a lot of dorsiflexion. So the key things at the end of this procedure is the patient's should have pretty good push-off strength compared to before the procedure, but they will lose dorsiflexion range of motion, so that's something they need to know ahead of time. There's different options for doing it and different flaps that are needed to allow for the opposition of the tendon. With a chronic rupture, you're looking at a reconstruction. So this is somebody who either gets missed or they try to treat it conservatively, and the tendon is still painful. The big issue that they have, most people with this treated conservatively, if it never heals or re-ruptures, is weakness. They don't like it. The ankle feels weak. They can't push off. They can't walk just for activities of daily living. Never mind any kind of athletics. So the rupture, you're looking at doing a big turn down flap with a FHL transfer, so taking the tendon and plugging it into the calcaneus. This is what I was talking about earlier. This guy's been reconstructed, so now both his feet, just at the resting posture, are pretty much equivalent. His left foot would have been dropping down a little bit more in this picture. And that's the tendon transfer, taking it from the FHL. There's really no morbidity to doing that, which is interesting. You don't lose push-off strength in the great toe. You really don't lose power. There's not any issues with transferring this tendon. Let's see, skip through these guys. These are different options. So there's a lot of papers out on this, kind of a hotly debated topic on what to do. There's really no consensus yet in the orthopedic literature. There's a lot of literature out of Canada where these are treated mainly non-operatively, as well as different case control studies. So there's new studies now saying that with the active progressive motion with non-operative treatment, it's as good as operative treatment for re-rupture rates. A lot of the data is still questionable. I think for somebody who's highly active or athletic, I lean towards fixing them. If there's any kind of a physiological or concern for infection, I'd stay away from it. So bottom line, surgical treatments got a higher morbidity. There's surgical complications, hospital costs, but there's a lower rupture rate, which is 2%. Non-surgical is 18%. So There's also a decrease in strength and endurance with the non-surgical treatment. So that, I think, for me, that's the main issue with not fixing these. There's a complex rehab protocol, which essentially involves early weight bearing, progressing to full range of motion strength. I don't let any of these people return to sport by at least 6 to 8 months, sometimes a year. It can take that long to recoup because you have so much atrophy in the gastric soleus complex. So the big issues, if you do have somebody with an Achilles partial tear, grade 1, or just a gastroc strain or tear, you want to do no motion for the Achilles tear. For a muscle tear, it's different. You want to do passive motion is okay, just not active. Weight bearing is good. We know that the weight bearing causes a safe amount of stress when it's done properly for the tendon to help the collagen fibers align to reform the structure. The re-rupture rate is the highest at 6 weeks to 4 months, and during this period is when the tendon is healing. It's at the highest risk because there's remodeling occurring. So the absolute earliest return to play is 6 months. That's based on the literature. For me, I'd push that, depends on the sport. I'd push that back a little bit, especially if they had a lot of tendinosis or weakness in the tendon. And you want the tendon to be really tight. You don't want to lose repair. So usually these people lose dorsiflexion postoperatively. Complications, re-rupture rate, wound infection. So operative treatment's a faster return, but the early protected weight-bearing range of motion is beneficial. So at this point, the results are still out on the Achilles. So what about insertional Achilles tendinopathy? This is very common, very, very common in any athletic sport or where there's a cleated athlete, whether it's spikes or soft cleats, socks, doesn't really matter. Cleats can cause problems as far as impingement. They're poorly designed. They cause a lot of posterior insertional Achilles pain and issues, especially in the running or jumping athlete. Insertional Achilles tendonitis is a little bit different, so we'll talk about some of the same issues. And then again, I'm bringing up the tendonitis. You've probably seen in the literature, there's words like tendonitis, tenosynovitis, tendinosis, peritendinitis, tendinopathy, peritendinopathy, tendovaginitis. All these words are confusing. All this stuff, it doesn't really matter. Basically, what's happening in the tendon is you have inflammation. In this region, there's poor blood supply, so that inflammation becomes a degenerative process. And you can have that process in somebody who's really young, which is surprising. So you don't have to be old to have this degeneration. You could have somebody in their mid-20s have it. So the main things we focus on in the Achilles is the tendinosis and the peritendinitis. So the tendinosis is a degeneration I'm talking about. The peritendinitis is the inflammation of the surrounding tissue, which is almost like a synovial lining for the tendon. So in athletes, you're going to see this in impact sports, direct correlation with intensity level. There's micro tears that occur constantly. So just like anywhere else in your body, there's micro tears occurring with any sport. Incidence in athletes can be as high as almost 20% with repetitive impact loading and running and jumping. The Achilles, like I mentioned, is the largest, strongest tendon in your body. So tremendous forces going through it. 5 times your body weight is going through your ankle with the loading gait phase. So with running, it could be anywhere from 15 to 20 times your body weight in newtons going through the Achilles tendon at the insertion. So there's lots of overuse syndrome, postural problems. These are all things that need to be evaluated. So whenever you have an athlete who's complaining of insertional pain, you need to look at their foot. Are they pronating? Are they varus? Are they cavus? Do they have an ankle contracture? How are they training? Is it too excessive? Are they taking breaks? Is it uneven ground? Is it a slanted surface that can cause perineal issues? Training errors, sudden increase in duration, intensity, or distance. So I always tell people everything is a progression. You have to, after every injury, even return to play scenarios after a season, you have to have a progression that's so critical. And then poor footwear, worn out shoes, poor capture of the posterior structures in the ankle. All these things are important to evaluate first before you start doing anti-inflammatories and modalities. So basically what we were talking about before was where the tendon was ruptured. You're getting the tendonitis or the tendinosis in the previous talk. The insertional one is a little bit more distal, and that's the kind of the pump bump that you see a lot of times. You're going to see these a lot in runners. As before, there's other different issues that can cause it. But you can have bursitis, which is usually present. So that Kager's fat pad I was showing you before is the source of a lot of that inflammation. This is most successfully treated non-operative, like 90% of the time. Rarely does it require any intervention. So there's retrocalcaneal bursa, which is this blue circle right here, sitting behind the Achilles tendon in that fat pad, and that's where a lot of this inflammation occurs. So that's the area of target or focus for any modalities, such as E-stim or different topical anti-inflammatories, in addition to stretching the calcaneus. So when you look at this, the whole Achilles tendon is a fixed length. So if you're going to stretch it, it's got to be in the gastric soleus complex. It's the only area that you're going to get some relief. So as I mentioned, there's a broad insertion on the posterior aspect of the calcaneus. There's extrinsic and intrinsic factors, but usually it's repetitive microtrauma. So you have a small injury, it doesn't hurt at the time. You keep playing and running, and it gets worse and exacerbated. So common theories of what's going on here. Is it a vascular problem? Is it an age problem? They don't really know at this point. The big thing, though, is the blood flow. So some people feel that there's a lot of blood flow, which is leading to increasing in turnover of the tissue and poor ability to heal. There's other people that think there's not a lot of blood flow. So I'm of the camp that I think it's a microtrauma that accumulates over time and has difficulty healing due to the microenvironment not being ideal. So when you get an X-ray, you'll start to see some changes. So a lot of people think that they have bone spurs, or these are pieces of calcaneus that broke off. This is actually inflammation. So this is chronic tearing and healing and tearing and healing, and the tendon starts to try to heal with bone at this transition site between tendon and bone. So this is a hallmark of this has been going on for a long time. Differential diagnosis: stress fractures, Haglund's deformity, posterior ankle impingement, plantar fasciitis, non-insertional Achilles tendinopathy. So all these things are things you need to look at, especially the plantar fasciitis and the posterior ankle impingement. This can happen a lot with a lot of plantar flexion injuries. When you feel the posterior aspect of the ankle in the course of the FHL, if there's any tenderness with push-off or plantar flexion of the great toe, that could be a hallmark of posterior ankle impingement. Plantar fasciitis, this is also a difficult problem, which also can be due to poor footwear, different cleats and different spikes, causing pain in the medial longitudinal arch, exacerbated by an Achilles injury or Achilles contracture. So the plantar fasciitis needs to be addressed as well. So you're going to have pain, swelling, burning, stiffness, made worse with stair climbing, hard surfaces, strenuous activity. A lot of these patients, this is going to be debilitating, especially for a lot of athletes. They're going to try to push through with this stuff, but they can't. No matter what they do, they're not going to be able to do it. So here's an example of some inflammation you can see in the posterior aspect of the calcaneus. This is all the stress reaction in the bone, so there's tremendous inflammation. This is the retrocalcaneal bursa. That's usually where a lot of the pain is. It can be directly at the insertion or just in front of the tendon, so you need to squeeze in front of the tendon to be sure. Do the exam we talked about earlier to be sure there's no contracture, as well as make sure there's no rupture or partial rupture. So weight-bearing x-rays are important. You want to look at any calcification or osteophytes. More studies showing that little spike we talked about earlier. So that spike is just a response to the chronic inflammatory cascade of the healing and the chronic tearing. MRI is usually important because of one thing. There's a few papers that show with the predictive value for non-operative treatment with grade 3 changes where you have inflammatory edema inside the tendon itself. It's a poor predictive indicator for non-operative treatment. Those are usually requiring surgery. Treatment protocol is complicated. Usually what I begin with is to calm it down, cam lock or boot, shut them down from activity, anti-inflammatories, gentle stretching modalities, work on these issues. They can still condition open chain for the quad, hamstrings, but you want to slow down any plantar flexion or forced dorsiflexion. Even sometimes a shoe lift can be helpful in the acute term. Non-operative modalities, there's not a lot of good evidence out there, but eccentric training is important. So trying to strengthen the tendon and eccentric load is good for any tendinopathy or tendonitis almost anywhere in the body. But there's not a lot of good evidence for it. Absolutely never ever inject cortisone anywhere near the Achilles tendon. There is some modalities and treatment protocols and some role for things like PRP injections in the retrocalcaneal bursa as well as stem cells. The data is still out there yet. So you'll have all kinds of different modalities you can do to try to offload the area. I had one of my baseball players who had this, and we gave him lidocaine patches that he put in the back of his cleats, as well as offloading strips to offload the central portion that was painful. That he had a bony spike on his x-ray, and that helped him push through. So there's a lot of little modifications that can be performed. Surgery, we head in this direction after 3 to 6 months of non-operative treatment. Basically what we're doing is we're taking off this posterior spike as well as the Haglund's bump. The Haglund's is normal, so a lot of people have this bump in the back of the calcaneus. That's a cam function, so you have similar things in your finger. What it does is as the foot dorsiflexes, it causes a posterior pressure, redistributes the forces from tension to a compression force in the tendon, so it actually increases the surface area for the tendon. Operative treatment is similar to the repair, dissection, clean out the tendon itself, remove the bony impingement structures. We do a midline incision. I take down almost 2/3 to 50%, even more than that, of the tendon itself without any evidence of any rupture. I don't like using anchors or different suture bridges. I think it's a foreign body which causes issues. So there's the area of resection that we're taking for the Haglund's deformity, and there's the suture repair at the end of the procedure with buried subcutaneous knots. So that's the resection, how it appears at the end. Complications. After surgical treatment, you can have superficial necrosis, scar, hypersensitivity. With the technique that we're using, it's pretty nil. I have not had any issues. You can have a rupture if the patients aren't careful. So in summary, Achilles injuries are very common in middle-aged population. X-rays show important evidence of chronic pathology. Non-operative treatment is successful, but if it fails, you're heading to surgical intervention, and it's usually pretty good, about 85% satisfaction rate. So non-insertional Achilles tendinopathy. This is kind of a similar or a precursor to the Achilles rupture. So we're talking about some different modalities here. So this is the triad of pain where you have limitation of activities, focal swelling, and degenerative changes. This is usually in the athlete, not so much in the sedentary patient. Non-insertional is going to be 2 to 6 centimeters from the insertion, which is that watershed region. We talked about the anatomy. So again, repetitive microtrauma, mechanical imbalance, increased strain. There's also genetic variance. This is where we talk about the vascularity. Some people think it's increased. What we used to think is poor vascularity is going to lead to rupture in a tendon, whereas recently we're saying that when it's undergoing neovascularization, that's when the ruptures occur. So there's multiple stages where you go through tendonitis with peritendinitis, leading to eventually tendinosis, which is the final stage. In the tendinosis, you have the mucoid degeneration and you're susceptible for rupture. So clinically, it's going to be a similar presentation, except it'll be higher in the tendon, about 6 centimeters from the insertion. What you're going to look for is ankle instability, malalignment, and of course contractures. A lot of these people are going to have a contracture. There's going to be a nodule that's going to move as you plantar flex, dorsiflex the ankle. If the nodule or the pain stays in one spot, then it's the inflamed tendon itself, the peritoneum around the tendon. If the nodule moves up and down, then it's the tendon itself, which is not as responsive to anti-inflammatory medication as the peritonitis. Again, same workup with the x-rays, MRI, ultrasound. Here's an example of a guy who had an ankle replacement who has calcifications within his tendon. MRI showing a thickened fusiform appearance of the tendon with a central area of edema. Similar picture here. So pretty much same pathologies. The insertional as far as the treatment modalities go. Doing the eccentric exercise, they think that decreases the neovascularization. Some studies say that it helps after 12 weeks. So that's going to be a forced concentric contraction and then a slow eccentric contraction with full body weight on the affected limb. Shockwave therapy, steroid injection, obviously you don't want to do that. PRP has some promising results. The data is still being evaluated, but most people have improvement at 1 year. Some people say that there's no difference between the PRP as well as the eccentric training program for tendinosis. There's a breezement where they put fluid in the peritoneum, and that has shown to break up some adhesions with saline, which is just as effective as the PRP in a lot of controlled studies. I like using night splints, but they show no benefit. Topical applications, like I talked about with the diclofenac gel patches, can help. And then here's the breezement where you're putting in an injection of fluid into the pseudosheath to help break up those adhesions. Goals of surgery are to resect the mucoid tissue, the damaged tissue that's leading to the degeneration. You want to do this at least for 4 months of conservative treatment, depending on the timing of the injury. So absolute indications for surgery are going to be obviously ruptures. A relative is going to be tendinosis over 6 months, and then contraindication is poor health, poor skin integrity. Similar surgery, long decision, open debridement, over 80% success rate, which is really good. And then 50% debridement, you tubularize it, or if it's greater than 50% debridement, you're going to do FHL transfer. So if you're compromising the tendon, you need to back it up with the FHL. It does two things. It gives you power. Number two, it brings the blood supply in for it to heal. Complications, same thing with any Achilles injury, is skin necrosis, FHL transfer. You can have issues with the great toe. And weakness in plantar flexion. So in summary, non-inflammatory, degenerative, multifactorial. The key really with this stuff is to rest early, begin eccentric exercise, anti-inflammatories, Cam Walker boot, immobilization. Shut it down until you have control of the symptoms. Then you can progress with modalities with the structured return to play program as symptoms permit. The emphasizing, again, is the injury prevention, being sure that your surveillance for gastroc contractures as well as Achilles contractures, any inversion, appearance to the foot, having proper training surfaces as well as shoes.